Now we are ending the session, and we have to thank very much speakers and the audience. We are on time, and I have an announcement. Stay in the audience because there is the lecture of Ciro Esposito coming and presented by our president.
So before lunch we have the sports lecture, and it's going to be a pleasure to introduce Professor Ciro Esposito from NATO, former president of Espes, and next the Congress chairman is Sorrento, and he's going to be in charge of this nice presentation.
Thank you very much, Mario. Thank you very much, the Espes Executive Board for the invitation to give this lecture of pediatric application of ICG fluorescence technology. As you know, ICG fluorescence dye and water-soluble molecule. Next. And as for pharmacodynamics, ICG is rapidly bound to albumin and is near instantaneously visualizing target organs that can be of GI or renal or other structure. I will show you in my slides. Next. Is important the timing of injection because can vary according to the pathology. In general, for gallbladder you have to inject the day before. For the other indication you have to inject intraoperatively or intravenously or directly into the organ, as you can see in the slides. Next. The indication, probably the main indication is gallbladder pathology, above all cholecystectomy. There are some reports of adult literature in the last 15 years. We started to adopt this technology in pediatric surgery 6 years ago, and some others are varicocele, renal surgery, tumors, but you can see there are a lot of indications that you can have. Next. The technique. The technique, for sure, to use the technology, for sure you need a vial of ICG, and then you need the system, the optic, and then the camera, and then the software. There are two possibilities. There is the old camera and software. When you switch with the pedal to ICG view, you have a grayscale view, and the new Rubina system, they remain in color, and to change, to switch from a normal to ICG, you have a button on your camera. Next. Cholecystectomy, I think is the main indication. Why? Because if you analyze the literature, there are still a lot of complications reported in cholecystectomy. Next. And why? Because above all in pediatric surgeries, as you can see, compared to an adult experience, we operate at least 30 cholecystectomy per year compared to 300 adults. For this reason, to have a clear view of biliary anatomy is extremely important in pediatric surgery. For sure, there is sometimes not always the classic biliary anatomy. There is the anatomy of vascular or biliary anatomy. For this reason, you need a system that permits us to see better the biliary anatomy. Next. And as you can see in this case, this is a pre-ICG era. You identify the structure not very well because there is a dilatation, but you don't know exactly where is biliary tree, and you have the risk to have a complication. Next, thanks to ICG, you have the possibility to do this. You have a real-time biliary imaging. Next. It's important to standardize the injection because to identify the gallbladder you have to inject the day before, because this is took by albumin, then go into the liver and then go into the biliary tree. For this reason, if you inject a few hours before, you can see the liver green and you have not a good view. For this reason, it's preferable to inject the day before. Next. And you have to standardize, as I told you, the technique of this section to avoid a liver interference. As you can see in the left side, if the liver is green, you have not a good view. Next. For this reason, you have to use this vial. You have to dilute the vial of ICG with 10 millimeters of sterile water, and then you have to inject the 6 milliliters the day before surgery, about 12-15 years before. And you have an excellent view, as you can see in the videos. Next. You can see this is standard view. You switch with the pedal. As you can see, as is so clear the anatomy, you can see the gallbladder, the cystic duct, and the main biliary tree, and you can dissect the fatty tissue without risk. Next, I have several videos to show you. As in this case, as you can see, there is a lot of adhesion. It's not clear the anatomy. You can switch to the pedal, you close a little bit the focus, and you can see there is an angulation of the cystic duct. And thanks to ICG, you have a clear anatomy and you have no risk of complication. Next. And then you can start your dissection without problem, switching from normal view to ICG view, and you have a clear view. If some doubt, you can switch. Next. And then you can see always very well, and you can dissect. Sometimes there is anomalies, but I think thanks to this technology, you have a very, very clear view, and also for trains, it's easy to perform cholecystectomy thanks to this technology. Next. And then also when you have to clip after the isolation, you have to check where you have to position the clip. You can see where is biliary, main biliary tree, and then you clip some section the cystic duct. Next. And it's useful also when you have to remove the gallbladder, because to avoid to have a not good plane, you can see very well the gallbladder inbreed. Next. And then there is the new technology. With the new technology, with Rubina system, you can remain working in color, pushing the button on your camera. You have the biliary tree that became green, and you can work in color, and for sure it's easier, and you can keep all the time with ICG view as you prefer. Next. And for this reason, the dissection is easier, as I showed you for the old version, but in this way you can keep in color, and then it's easier above all when you have anomalies. Next. And you can see very well the structure suddenly after the introduction of instrument, and also when there is a dilatation, as in this case, as you can see, the cystic duct is attached to the main biliary tree, and you can find a plane. There is also a huge artery that you can see very well on the gallbladder. Next. And you can see very well that you can dissect the main biliary tree from cystic duct thanks to this technology. You can send the plan on dissection, and you can dissect the vessel. For this reason, with this technology, the procedure is easier with less risk. Next. And then, as I showed you, you can remove the gallbladder easily. Next. And as Maria showed you yesterday, there is some anomalies that is difficult to identify without this technology. This is a standard cholecystectomy. Is also during a course. I dissect the gallbladder. You can see a green duct that appears, and this is the Lashka duct. And I remove the gallbladder, and then I move to the Lushka duct and clip it to avoid to have bile inside the abdominal cavity. And without green, it's difficult to identify. We showed in our series yesterday that there is one case without ICG that had a complication in post-operative period. Next. And also for renal surgery, you can adopt them. Next. Usually we perform nephrectomy in laparoscopy, but for tumors we prefer robotics, as in this case, and robotics has the system called Firefly, an ICG integrated, and you can use use ICG. If you have Da Vinci XI robots, in robotics we prefer to use Hemlock to secure the vessels. For this reason, also in robotics, you already have this technology integrated in the system. Next. I think that probably the best indication for urology is partial nephrectomy. Why? Next, because you can identify, first of all, the vessels, the ureter, and you have a very, very good view. I will show you in these videos next. First of all, this is the old system. You can, first of all, you have to perform a cystoscopy, put a catheter in the normal ureter, you inject in the catheter ICG, and in this way you can differentiate the normal ureter from the dilated ureter. As you can see, the normal ureter in green. The two ureter are attached and it's difficult to identify them. Next. And as you can see, thanks to green, we are isolated the normal ureter from the dilated one. For this reason, you have no risk to damage the other ureter. Next. Closing the focus, you have a better view. And then also to identify the vascularization. This is a lower pole nephrectomy, and to identify vascularization on lower pole, we inject intravenously the green. You can see there are two vessels that go to the lower pole. There is the main renal vein, the renal artery, and then two vessels that you can clearly identify, switching for sure from green to normal. Next. And then also at the end of the procedure, after clipping the vessels of the moiety that you have to remove, this is an upper pole partial nephrectomy. You have two possibilities. You have the software in green or the software in blue, as in this case. You close the focus and you can see the demarcation line between the vascularized kidney, lower part in blue, and the vascularized, the devascularized upper pole that is not blue, and you can cut, you have the line to cut in between. Next. And then this is the same thing on the other side. Using green software, you can see the lower pole devascularized. For this reason, you can use this technology for several steps of the technique. Next. And for sure, in color is better. You can see the ureteral part, as you can see the normal ureter in green and the huge ureter on the upper part. The two ureter are attached, but thanks to green, the normal ureter remain on the bottom of your screen, and you can isolate the others without having risk. Next. And then this is the isolation. The normal ureter is safe, the bigger ureter is isolated. You can clip, in this case we use a sealing device to seal it and then to move to the kidney. Next. And then you can use this is an upper pole partial nephrectomy. You inject it with green and you can see the vessels. There is a small upper pole to remove. Next. But there are also other indications, as renal kiss. Next, we inject, this is in robotics, if you inject the dome of a kiss remain without color. For this reason you can easily identify it. As you can see, you can section it and then you can put fatty tissue inside to avoid recurrence using robotic technology. Other indication. Next, recently, thanks to François Varlet, we started to perform percutaneous endoscopic mastectomy in children with gynecomastia, and we create a space thanks to balloon. Then we introduce the trocar where we remove fatty tissue with liposuction, and then we remove the gland. And next, it's easy to identify the gland because through the nipple we inject the green inside the gland. You can identify the gland. Without green it's difficult to do it. Thanks to green you can identify the gland, and you can section the gland, leaving only 1 centimeter of gland behind the nipple. And as you can see, we use a sealing device to do it. You can see the gland because it's in green. If you switch to clear view, you have not a good view of the gland. This is a potentially another indication. Next. And also for the treatment of anal fistulas, we treat it using endoscopic technique, but to identify the anal part of the fistula, you can inject in the fistula the green, and you enter in the anus with anoscope, and you can identify where is the fistula to treat the orifice, anal orifice. Next. And then for sure, one of the classic is varicocelectomy. Next, as you know, we perform Palomo procedure. It's important to skip lymphatics. You have to inject inside the testis, and in 30 seconds you have the identification of lymphatics. It's important to save at least a couple of lymphatics to avoid hydrocele. With more than 100 patients, we have 0% hydrocele using this technique. It's absolutely easy. It's a 5 minutes procedure because you identify the lymphatics immediately, you can isolate them, and then you can clip all the spermatic bundle. And then you can isolate. Next. You can clip and section as usual. Very, very safe procedure and fast procedure to perform thanks to ICG. Next slide. And then this is the end. You can check, you save the lymphatics that are saved. Next slide. Then you can use in oncology. There are some papers published in the literature that can be used to identify nodes. Above all, the adults adopt a lot this technique, for example, for testicular tumors to identify nodes, or for pulmonary metastasis, in case of hepatic tumors, and you can identify the metastasis. Next. Or in case of lymphoma or for abdominal mass removal. There are some literature above all in adults about this point. Next. And then also to identify nodes in case of lymphomas, you have to work in thoracoscopy. You can inject directly into the lung, and then you can switch to green mode, and then you can identify the pathologic nodes. Next. And then you can perform, as we perform partial nephrectomy, in the same time you can perform partial splenectomy. As you know, the spleen have a segmentary artery for this. You can inject, and after clipping and section the part of the spleen you have to remove, you can see the line of demarcation. In this way you have no risk to have bleeding, and using always sealing device. Next. And also for ovarian pathology, in case of tumors or in case of torsion, you can perform it using robotics. Robotics has excellent sealing the device in case of tumor to perform ovariectomy. Next. And you can use ICG to identify pathologic nodes, or in case of endometriosis, the eye of endometriosis are not colored, as you can see on the right side. Next. And then in case of adnexal torsion, before the rotation and after, you can check if there is a good vascularization of the ovary. Next. There are a lot of indications. I think the limit is only our fantasy, because we treat a lot of pathology from thorax, abdominal, GI, urology. For this reason, probably there will discover more indication in next future. Only some consideration: to use this technology, you need a special equipment, camera, optic, ICG vial. Also, if all the brands has this technology, if you buy now a new column, it's important to know the timing of injection, that change according to the organ that you have to study. Probably the only pathology which you have to inject before is cholecystectomy. For this reason, the patient has to go to the hospital the day before surgery to have an injection. For the other indication, kidney, varicocele, node tumor, you have to inject intraoperatively or intravenously or inside the organ. I think that there are real advantage for the surgeon. There is no adverse effect in our experience and on the basis of a literature analysis. You can use the same vial for different patients, because you can use the vial after that you put the sterile water inside for 6 hours. For this reason, during the morning you can use for several procedures. Next. These are the main indications. For sure, cholecystectomy, partial nephrectomy, varicocele, but also tumors or gynecomastia, as I showed in my experience. I think for cholecystectomy, varicocele, partial nephrectomy is mandatory because surgery is easier thanks to ICG. Next. And for sure, I think that ECG fluorescence is safe, useful, and a versatile technique. Probably in the next future we will have more indication, and to have a better visualization of anatomy and of organs, and above all, I think that increased safety of laparoscopic procedure, above all if you have a training center, use this technology. Next. I would like to thank you of your attention, and I would like to remember to invite you in Sorrento next year. It will be an amazing meeting because Hilton Sorrento Palace has an amazing venue, and we have the pleasure to work with IPEG for this reason. We are waiting for you and for your contribution. Thank you very much for your attention.